All right, so good evening, good afternoon, everyone. So we have such a great speaker today, Dr. Pat Camp. She's going to talk about the approaches to enhancing Indigenous lung health and health in Canada. So Dr. Camp is an associate professor at the University of British Columbia, Department of Physical Therapy, and a clinician scientist in the Center for Heart Lung Innovation. Her research is focused on pulmonary rehabilitation for hospitalized patients and also telerehabilitation. She holds grants from the Canadian Institute of Health Research, Michael Smith Foundation for Lung Health, and British Columbia Lung Association and Industry. So, Dr. Kemp, you may start and speak a little bit more about yourself if you would like.
Great. Well, thank you. And thank you for the invitation. I know this is an unusual situation, and actually this will probably be my only international talk this year, as so many things have been disrupted and canceled. So thank you for those that have called in and making the time today. And of course, this will be archived. So the opportunity for ongoing discussions about this work can certainly continue. So thank you very much for the invitation. I'm going to share my screen, hopefully with some success here in terms of my slides. Let's go back here. And do those share okay, or are you still seeing my display?
So we see both of the screen here.
Okay.
You can make it.
Let me see what happens if I turn that off. And then we can, maybe we can do that. How does that look?
It looks great.
Okay, great. So today I'm here to chat with you about some of the work that we're doing with First Nations communities in Canada. And as Azita said, I am with the University of British Columbia. And most of my career has been dedicated towards research in chronic lung disease and most specifically COPD. This particular work is a bit of a departure for me. A few years ago, when I was fortunate to get tenure, I really had a bit of a soul search in terms of where I wanted to see my research go and what I felt like the bigger impact could be. And that led me to working with Indigenous communities here in Canada. So I do want to acknowledge some people right off the bat. My research partner is Travis Hollick. Dr. Hollick is with Karisakani Family Services. That's a First Nations, health society that provides primary care to a number of different communities. And these communities are listed here. And so I would like to acknowledge the people of the different communities that we've been fortunate enough to work with. Benna Rathburn and Barb Carlin are the research coordinators with this study, and Karen Bartlett, who some of you may know, she is an occupational environmental health researcher at UBC. She's also with us on our team. So to give you some context, for those that might not know Canada that well, as you can see, Canada is a large country. It's the second largest in the world, and it's made up of a number of different provinces and territories. So I'm from British Columbia, so that's to the very far left. And at the very bottom corner of British Columbia is Vancouver. And Vancouver is a city of about 4 million people, and it is the most populated city in British Columbia. But the work that I'm doing is located closer to Prince George. So you can see, I don't know if my mouse actually works here, but you can see that there is in the center of British Columbia, a smaller town called Prince George. It's got about 100 or 200,000 people. And then we are working in remote and rural communities close to Prince George. So the First Nations are one of the larger categories of Indigenous people in Canada. So in Canada, the accepted terms for the Indigenous people are either they belong to First Nations, or they are Inuit or Métis. So we don't use the term American Indian in Canada. These are our proper terms for the three different larger groups of Indigenous people. And so there are about 200,000 Indigenous peoples in British Columbia alone. And we have the most diversity in terms of First Nations. So there are 198 out of, I think, about 600 unique First Nations in Canada. So we represent about a third of all the nations in Canada live in the province of British Columbia. And we also have the majority of individual First Nation languages are spoken in BC. So I took that previous map of British Columbia, so this area here, and if we were to put those boundaries, I've just drawn them on here, you can see that a different way to cut up the province isn't by the communities of Vancouver or British Columbia, but there are a number of distinct nations that make up the First Nation areas. And so within each of these areas, there would be many First Nation communities. So Prince George is here, and so we're working with communities that are sort of in this central area. So, as I mentioned, most of my work is related to helping or improving health outcomes in people that have COPD. So, if you don't work in COPD, you might not be that aware of it. It's unfortunately a very prevalent condition, but there is actually very little public awareness about it. It is the fourth leading cause of death in Canada, and for the most part, most North American and European countries, it's caused by cigarette smoking. Sometimes people might have exposure to other lung irritants, but by and large, cigarette smoking is the strongest risk factor. And the cigarette smoke over a period of time causes damage to both the airways and the alveoli of the lungs, and that results in shortness of breath, low exercise tolerance, and a real poor quality of life for these patients. So when we typically think about COPD and we're looking at risk factors or we're looking at mitigating factors, oftentimes people are really focused on the individual lifestyle factors. As I mentioned, cigarette smoking, that is a predominant risk factor. And certainly we may look at age and sex and constitutional factors of an individual that may increase their risk. But we wanted to take a different approach to this lung health research. We wanted to have a better appreciation as the larger context of both the living conditions of individuals, the history of their experiences in Canada, and also how current general and environmental conditions can impact their lung health. So we've used this socio-ecological approach to lung health research when working with these First Nations communities. And so this particular approach, as you can see, it certainly considers the individual lifestyle factors, but it has an appreciation of both the social and community networks and also general socio-economic, cultural, and environmental conditions. And these may be related to how people access food, education, where they work, where they live, the healthcare services that they receive. We have with this model, a better appreciation as to the different determinants of their health and also the historical factors that may have influenced their health today. So with respect to First Nations individuals or Indigenous peoples of Canada, there are a number of different factors which have increased their likelihood to have chronic lung disease now. So when we look at general socioeconomic, cultural, environmental conditions, that higher level, there were a number of different things that happened to First Nations people that have an impact on their lung disease. And of course, colonization caused an enormous destruction and tragedy to First Nations people of Canada. But oftentimes people think, oh, well, that's this long ago thing that have happened. It's not so relevant now. But more recently, residential schools have been a current aspect of their lives. And so these were the boarding schools that were created, mostly run by the church at the command and direction and funding by the federal government to, in a sense, take the indigenousness of a person out and make them more Western. So to integrate them and assimilate them into the dominant society. So children were forcibly removed and placed into these residential schools where they experienced a tremendous amount of abuse, trauma, and lack of culture. And people can still think, oh, that's a long time ago. But actually, the last residential school in Canada closed in 1996. And many of the people that I'm talking with for these studies either went to a residential school themselves or their parents did. So this isn't some remote history of trauma. This is things that are current and that have impacted their lives today. More recently, though, 1960s, the residential schools were already being phased out. And so a new policy to try to, again, assimilate Indigenous peoples was something called the 60 Scoop. And that's where children were again forcibly removed from their homes, but instead were placed into foster or adoptive homes that were non-Indigenous, so typically in white homes. And so again, it had the same principle of people losing their culture, people losing their family connection, and a history of trauma associated with that. And then the Indian Act is still our federal government's approach to dealing with Indigenous peoples. And while there's certain protections in there for them, there's also many aspects of that act that limit their ability to have equitable health. So all of those create risk factors for lung disease. Now, the air quality of those residential schools in the past was quite poor. These were, although well funded to some degree, they still were not well run. So they were poorly ventilated, poorly heated. There was minimal health care. There was a well documented history of abuse and neglect of these children with no access to their traditional health knowledge. And there was a high prevalence of lung infection. You can see that this is a classroom. There's a lot of kids in a small space. And in poorly ventilated and heated rooms, there was a lot of history of respiratory risks, of respiratory infections in these children. But that's not just the past. Certainly a lot of First Nations communities continue to deal with poor air quality. And so a lot of these communities in remote and rural areas are having to deal with forest fires. This was just a couple of years ago. In the middle of the day, there was a fire in one of the communities, near one of the communities that we're working in. And you can see, like many places in the world, a real problem with air quality. That's my hand holding some ash in Burns Lake that comes from a local manufacturing industry. So even day to day, there's a lot of problems with air quality. And there's a lot of heavy industry in these remote areas. So they all have an impact on the current air quality, and of course, increased risks for lung symptoms as part of that. Now, another thing to focus on is also just how are people able to access healthcare? And certainly there is a history of discrimination and racism against these people that continues to this day. And it also is just a matter of sheer access. So when we look at things like pulmonary function tests, although there are some places that do have the labs, for the most part, for many of these places, they're just small spirometry testing labs. And to get a full detailed lung function test, you usually have to go to a larger city that may be 4, 5, 6 hours away in good weather. And similarly, for specialist consults, vast majority of them are located in the Vancouver area and some in the interior, what we call the Okanagan area, but really just one respirologist that services the entire north, which is, although doesn't have as high a population, there's still well over 1 million people that would live sort of from this Kamloops area above. So there is not enough services, and most people don't want to work in these northern areas, and so that really has an impact on access. So together, there are many of these factors that, whether it's work or air that we breathe or healthcare services or past history of trauma, they certainly all have an impact on chronic lung disease. But there are, of course, individual lifestyle factors which impact the lung health of First Nations people. And so it's well documented that there is an increased risk of bronchiolitis and pneumonia and TB in Canadian First Nations children, partly related to overcrowding in houses and, again, lack of access to healthcare services. And smoking is certainly also very prevalent in these communities. So this is data from, it's 2006, but there isn't any reason to think that this has changed, where it's looking at the prevalence of cigarette smoking, so the proper term in an Indigenous culture, non-traditional tobacco use, because there is traditional tobacco use for sure. But in Canada, we're about at the sort of 20-ish% of the population is a current cigarette smoker. But when you look at the First Nations people, that is typically more than double. And in some cases, as much as 50% of the population are active cigarette smokers when you look at in the very far north. So together, we know that Indigenous people have both a historical increased risk factors and current increased risk factors for COPD. So based on that, we would expect to see a high prevalence of COPD in this population. But in fact, what we're seeing is actually quite low numbers based on the current methods of measurement. So if we were to look at a couple of survey sources in both Canada and the United States, looking at self-reported physician-diagnosed chronic bronchitis, it's sort of a proxy of COPD, that has come out at about 6.5%. And if we were to go directly to these communities and look at the electronic health record and look for physician-diagnosed and recorded COPD, it's about 4%. So these numbers are quite a bit similar to what is reported in the non-Indigenous communities. And so we felt like there was likely a gap in terms of understanding the true prevalence, given the higher risk factors, given the higher prevalence of smoking. We would expect to see a higher prevalence of COPD. So these past looks at prevalence really, a survey doesn't really get at the heart of it. It's a self-reported condition in those surveys, and we know that there's poor public awareness about COPD. And it hasn't really looked at it from that more socio-ecological approach of what are the sort of risks that people are reporting. They also don't have much engagement with the community, and of course, the biggest limitation is that there's no direct lung function measurement. And so to really get an idea of the true prevalence of COPD, you really do need to do lung function measurements directly. There also wasn't a direct measure of risk factors beyond cigarette smoking. And for the most part, a lot of Indigenous health research is really looking at it from more of what we would call a deficit approach. So just count up the numbers, come up with an answer that says, yes, they have worse health outcomes, and be sort of done. Whereas we wanted to take a research approach that not only provided a true picture of the prevalence of COPD, but also began the conversation around, okay, well, how can we improve diagnosis? What can we do around management? How does Indigenous wellness principles and knowledge factor in? So we wanted to not take a deficit approach, but instead look at something that an approach that both increased awareness and hopefully improved diagnosis access, and also developed a community-based solution to addressing the problem. So we were very fortunate that the communities that we asked to work with already had a great history of success with physiotherapy department and the Faculty of Medicine at UBC. So we had already been working with this particular health society called Socio-Ecological Family Services to have our medical students and our physio students work with preceptors in those communities to have a better understanding about rural health. And so we already had that relationship. So when I came in and asked, hey, is lung health maybe on your radar? And it really wasn't, it allowed a dialogue to begin. So we have societies like the Socio-Ecological Family Services, and then British Columbia is unique in that we've actually created our own government-funded First Nations Health Authority, which has a larger infrastructure, I guess, to providing healthcare services. So there is already a pretty good infrastructure in place in terms of asking about research, having ethics, having an appropriate panel to review the work, etc. Also, the First Nation communities in BC are extremely innovative when it comes to things like telehealth infrastructure, light years ahead of where a lot of non-First Nations communities are in terms of getting telehealth as just part of their regular health care. And so that allowed us to, when we started to thinking about solutions, to be able to really partner with the communities and think outside the box. And so there's also Indigenous methods of collaboration and Indigenous knowledge of wellness that we knew would really inform the work and would be able to, when we thought about community-based solutions, would really be strong in that area. So from that, I'm going to get more into specifics now about the specific study. And so the name of the study that we proposed is called Beas Iltus, a strong breath. And so I'm not good at carrier language. You'll hear it pronounced better in a minute. But it is a team of UBC and County Family Services researchers that have come together. And the idea is to identify the prevalence of COPD in these 11 First Nations communities in BC. So we have different members of the team. As you can see, some of the members of our team are First Nations people, and they are a key part of having the research done in a good, acceptable way. So the nations that we're going to, so I mentioned Prince George, so that was in the middle of the province of British Columbia. And so there's a highway that goes from Prince George all the way to the coast of BC. And so there are a number of First Nations communities up and down along the highway, anywhere from sort of an hour to 2 hours away, up to some of these very remote communities that you get to by a pretty rough road that's more like 5 or 6 hours away. So we have visits to all of these communities where we conduct our study. And so we just didn't, kind of show up and start doing measurements. We really needed to look at a community-based research principles with respect to this work. So, we first introduced ourselves to County Family Services, and we had already that existing relationship. So it was more about myself personally introducing myself. And then from that, it was decided, well, in order to establish relationships with community, we really do need to just increase general awareness. So let's put on some lung health days. Communities will come, there'll be some booths, they'll start hearing about lung health, and it'll start to get that relationship going. From there, we convened some advisory board meetings where representatives of the different communities came together and gave us their thoughts about how we should proceed with the work. And then we started to write grants. And so we wrote grants to the BC Lung Association, the Canadian Institute of Health Research, which is like kind of this equivalent would be the NIH in the United States, and then a BC group called the Michael Smith Foundation for Health Research. And so once we received funding, there was a number of different principles that we needed to follow. We need to be very flexible in our data collection, recognizing that these are small communities. Things can change rapidly. There can be a community celebration or a community death where your data collection day has been postponed. But on the other hand, sometimes something happens, and if you can just be really responsive and get into the community and take advantage of an opportunity, then we had to do that as well. These are long studies, and so the idea, it's a long view to build trust and be present and to be a part of, to be a face in the community. So I make sure that I go there as much as I possibly can, and to always build into the grants, giving back, so that we're not just going in there, taking some measurements, writing a paper and sort of being done, but that we make sure that we have built right into the grant ways to either bring equipment in or training or increase capacity or have more of a sustainability approach in terms of access to healthcare, specifically around lung disease. And then make sure that we're always monitoring and updating the communities about where we are and what kind of results we're seeing and getting their perspectives on that. So this has been the approach that we've taken. So our first lung health days were very successful, and they really helped to identify some to the community and to us that we were on the right track in terms of understanding that lung health and lung disease is a burden. So we had a number of, we didn't have 168 health days, but we had about, I want to say 5 health days, and about 168 people participated, which was excellent. And so we'd ask some questions with simple surveys, such as, are you currently smoking? And so 45% of the respondents said yes, they certainly were. So definitely those high prevalence rates that we were seeing nationally. And when we ask people, well, are you exposed to gas or fumes at work, or do you have some of these respiratory symptoms such as breathlessness, 40%? And these were just people walking by the booth. So they may be more likely to come to the booth if they had respiratory symptoms. But nevertheless, it wasn't a small proportion of people walking by that reported things like breathlessness, cough, fatigue, those kinds of symptoms that we're used to seeing with people with chronic lung disease. Whether it's COPD or asthma, of course, or other things, we're not sure with this simple question. But nevertheless, we did do a very quick and dirty screening spirometry at these lung health fairs. And we found that, just people walking by, about 16% did have abnormal spirometry, and we suggested that they go for further testing. This was before our formal study was really up and running. Like I mentioned, a lot of people were exposed to dust and gas and fumes. That should be gas, not games. And 65% were, we were seeing higher and higher numbers of current smoking depending on where we were at. And so that led us to take these results to our community advisory board meeting and say, people are reporting that there's a problem. What are your thoughts? And so these were some of the quotes that came out. One of the leaders in the community said, well, we might not really talk about it much in the community, but it is loud in the hospital. It's a very common reason why Aboriginal people go to the hospital. That was one comment. And then another person said, this is actually a real opportunity to create information. And the third person said, we've got to go the whole 9 yards. We need to, what do we need to look out for? What are our signs and symptoms? We need to know how to get a proper diagnosis. And then as a community, figure out how to manage if we have a problem. So that led us to create the Strong Breath study, and we identified 3 main aims. The first, the primary aim, is to estimate the prevalence of COPD. And so we expected that COPD would be highly prevalent. And so our approach is to not do strictly walk-ins or lung fairs, but to actually take a random sample of households. There's 13 communities, 11 nations, in 13 communities. And we would invite, with the random household, we would then invite every adult in that household, 30 years or older, to participate in the study. And we estimated we would need about 200 individuals to detect a 13% prevalence in the community. So maybe if other random sample population-based spirometry studies detected about 11%. So these would be the bold studies that were done by other nations. We thought that the prevalence would probably be higher, but we were conservative and thought, okay, we would be at about maybe 13%, so a bit higher. So we're doing pre and post bronchodilator spirometry according to ATS standards. We're doing the ATS respiratory questionnaire with additional questions around Aboriginal health, occupational, cultural activities, history, detailed medical history, as well as things that people are smoking, cigarettes, but also now, of course, marijuana and vaping are important questions as well. Our second aim is to get a better handle around the underdiagnosis of COPD. So we're looking at the MOAS, which is their health electronic record in Karisakani Family Services. And so for all the people that are in our study, we're going to go and look at their electronic health record and be able to ask, okay, well, is a COPD diagnosis showing up in the medical record? So what is the disconnect between people that are actually recorded as having COPD and then the people that we find in the community? So we're using more of an administrative data definition of COPD in terms of the physician diagnosis. So whether there's a record of a COPD diagnosis, whether there's a discharge note, whether there's a history of appropriate COPD medication with cigarette smoking, or of course, if there's already a pre-existing pulmonary function test in the electronic health record. So we can look at the disconnect between what we're seeing in the community with random sample versus the prevalence that's being measured if you use the electronic health record. And then because people want to know, well, what are the risks that we have now? We want to estimate the risk factors at the individual and community level. So this isn't trying to find novel cases of COPD. Certainly risk factors related to air quality have been measured, but we wanted to be able to provide some tangible information about, are there respiratory irritants in the First Nations homes that may be contributing to some of these symptoms. So we're doing an indoor and outdoor housing inspection, and then also taking measurements of particulate matter. So a 5-minute measure of particulate matter in 3 rooms of each house, and then also a 1-minute measure of carbon monoxide, carbon dioxide, humidity, and temperature as a proxy for ventilation, and also taking a vacuum dust sample. And so all of these measurements are done when we visit the community, and that's between September to May, in order to get the cooler months and to be able to have the houses a little bit more closed up, and then also to be able to make sure that there are people in the house as well. And so those measures, or the vacuum dust, is taken back to UBC, and that analysis will happen in the future. So that's a once-off measurement, a one moment in time. So I just wanted to play for you a video that we have, that the funder, actually, our BC Lung Association, was so excited about this particular research that they decided to put together a video about it. But I think it really captures this work in a more descriptive way. So I'm going to end my show briefly, and I'm going to go to this video. I can pull this together. One moment. There we go. And let me know if you do not see the video. Okay.
There's an inequity in healthcare. People that live in remote and rural locations don't have access to the facilities that we have, say, in Vancouver. So it's important to bring this kind of research into the communities, because you can't bring the communities to the research.
The name of this research project is called A Strong Breath and a Carrier. It is translated to Bellitos Pas.
The mandate of Carriacicani Family Services is to provide health and social services to the 11 member First Nations within the North Central British Columbia area.
The purpose of this project is to estimate the prevalence of chronic obstructive pulmonary disease in a number of First Nations communities, doing lung function tests with the people, and also measuring air quality in their home.
Primarily, I do the lung function testing on the participant, but I'm also involved in the home sampling as well. I like the travel. I like going into the communities. They're beautiful. A typical day for us would be leaving Vancouver at about 7 in the morning, getting to Prince George about an hour later, get a car, get our equipment, drive to one of the reserves, whichever one we're going to be working with, check in at the health center. We rely on Benna to find participants for us. She is our cultural liaison, and she's very valuable on this survey.
I do the interviews, and the interviews are about 45 minutes long. The most important thing to me is to have respect for community members and to gain their trust so that they can be open and honest when you're asking them questions.
We didn't just arrive in the community and start taking lung function measurements. It started with a fairly long community building engagement process. We talked to community advisory boards and got their perspective of, is this an important question? What would the research actually look like?
The advisory councils, they're crucial. They're crucial for projects like this. These are studies that ask a lot of personal questions. We're going into people's homes.
Carrick County Family Services role is to make sure that the research is being done in a good way, that the research is culturally safe, it meets the needs of the community, and it follows First Nations research principles.
None of this would happen without our advisory committee, and that advisory committee is made up of members of all of our member nations. The important thing for Carrick County Family Services is really about access to health services. So this project was really about getting spirometry out into the communities that we serve.
Spirometry is a very simple breathing test that can detect if someone has some kind of restriction or obstruction in their airways.
A lot of our community members are suffering with different ailments, and lung health is one. Most people, when you're interviewing them, because our community members have been interviewed to death and surveyed to death and researched to death, most people would like to see results.
By getting more information and understanding how many people have a condition, it allows for Carrick County Family Services to be able to bring in the kinds of assessment and treatment care that people need. It's definitely a strengths-based approach to research. BC Lung provided the first operating grant for this particular project, and that launched us to be able to apply for the much larger grant that continued the work. So it definitely was the springboard that allowed the larger project to happen.
We have 5 years to actually complete this work in all of the communities. The key to Indigenous research is that from the onset, there is something like the spirometry testing that is a direct benefit to the community, so it's not just research for research's sake.
We're both stronger together. UBC and Carrick County Family Services work well together, and it makes this project happen. So I really always love watching that particular video because I feel like it really provides a wonderful overview and a sense of how we, let me just make sure I'm back here, how we work together and there we go, how we work together as two organizations with this common goal. So I wanted to share some of the results with you that we've got so far. We are displaying both results from the random sample, but also we are collecting information people who are walking in. And the reason why we're doing that is like what Dr. Hollick had said, we want to improve access to these services. So it's not just for those that are actually selected in the random sample, but if somebody comes by the health center and they say, hey, could I get my tests, my breathing checked as well? We offer them that opportunity. But we are keeping that information separate because we understand that these are sort of different populations. So from the random sample as of May of last year, we had recruited 70 people and more women than men at that point. But we hope to be able to increase the number of men. We're having a hard time finding the men because they're often out of community working. It is a younger population anyway, and that is certainly reflected in the age of the people that we're recruiting. As we have mentioned, most have been either current or past smokers, and so that has, of course, been a pretty high prevalence. But when we look at the amount that they're smoking, actually, I was pleased and surprised to see that the exposure wasn't actually that high for many of these people. But they are exposed to work dust and the potential of other lung irritants, so that may be something to consider. And we had spirometry available for about 83% of the random sample at this point. So when we looked at the prevalence of COPD in that group to date, from the randomly sampled participants, it was quite high, 17.4%. Those in the non-randomly sampled group was lower at 7.5. And so this really just shows us the importance of actually doing population-based random sample research. We feel like the non-randomly sampled participants are lower. In some studies, people say, oh, well, when you get walk-ins, you get a higher estimate, an overestimate, because people are motivated by symptoms and they want to come in. I think for us, our non-randomly sampled participants are likely motivated by the fact that they're already kind of hanging around the health center. There's a small honorarium that's given to people that participate, and there's just something to do. So I think that we're getting a healthier walk-in group than we are from the random sample participants. But it is certainly much higher than the 13% that we estimated. So we'll see how the numbers come out. And again, compared to the community electronic health record, it's much higher, which you can see 17.4 versus 4%. And similar to our lung health days, the prevalence of respiratory symptoms are quite high. I'm not sure if I can move this thing. Yes, I can. So cough, for the randomly sampled participants, phlegm, wheeze, and dyspnea are all quite high, approaching even 60% in some cases. So it could be asthma, it could be COPD, it could just be response to irritants in the air, but certainly the respiratory burden is not insignificant. I don't have, can I do this here? There we go. There we go. I don't have data yet for the air quality measures, but I do have a few subjective notes and some things that that I was pleased to see in terms of reduced risk factors is that there were very few carpets. Almost nobody had a carpet in their home, and the climate is quite dry, so there wasn't a lot of moisture in these northern communities, and so the prevalence of things like mold wasn't too shocking. And a number of communities have housing initiatives, so people are getting into new homes. But there are still some risk factors. There is some poor ventilation. A lot of places don't have fans, or if the fans are broken or they're not venting properly. There is a high prevalence of smoking in people's homes. And because these are homes on reserve, it does get a little bit confusing as to who's actually responsible for repairs. So that's a key issue for sure in terms of what do we find, and then who takes on the burden of actually fixing problems. So like I mentioned, one of the key factors for our work is this strong partnership between Carrick-Sicani and UBC. And that strong team has actually resulted in very sizable grant success metrics. And so, we first started off with applying to the Canadian Institute of Health Research for planning grants so we could bring those groups together. We received those grants also from Boehringer Ingelheim, gave us money for some of that planning work. And then we put in the first grant for BC Lung and received money for that, did some more planning work, and then got the larger CIHR COPD prevalence grant. We then went on to request money for other initiatives. We put in a grant request so that we could start to look at what we call pulmonary rehab, or even just lung health and wellness programs, so that we are starting to act on the numbers that we're seeing. There was a smaller request for grant applications related to telehealth and telemonitoring for COPD, so we were successful in getting money for that. And then just recently, just last year, we put in a grant to starting to look at wildfire smoke exposure and how we can mitigate the impact of some of the wildfires that we were seeing up there while we were doing this other work, and try to have more of a community-based approach instead of relying on the federal government to inform them of air quality and to support evacuations and things like that. So we've been very successful in terms of grant funding, and I think we're a bit of a victim of our own success. We're certainly looking for bodies, and recruiting students has been an ongoing challenge for us, for sure. But nevertheless, we're very happy to have the support from the federal agencies and the local agencies in terms of this grant. So I wanted to just finish up with comments more in general about being a researcher ally, a term that you may or may not have heard, but it's typically one given when you are a non-Indigenous person and yet you're working in partnership with Indigenous communities. And so as a researcher ally, I've had the opportunity to reflect on my experience. And so the first thing is, I put together these 7 items, 7 things that I'm learning. And the first thing that has probably been the hardest is learning, in a sense, not to lead. So, of course, as a researcher, as a principal investigator, we're used to receiving research money and being in charge and being the direction and the leadership and the management of the grants. And so with this particular partnership, with working with First Nations communities, your leadership role has to be much more understated. It's not an opportunity to sort of be the big cheese. You really do need to take a backseat role, and yet in that you still have to be very organized because people do expect you to come in and make sure that the study happens. So you have to be ready, you have to be nimble, you have to be prepared, but you can't make a big show of it. And so that's been definitely a lesson learned as I've gone forward. It's been important for me to learn the history of the communities that we're working with, and that's, I'm not trying to say that I've received or have an understanding of the very complex cultural and historical timelines of these communities, but it does behoove you to learn a little bit about the culture, the language, and the history. But don't try to make it like it's yours now. So I don't walk around with tattoos. I don't pretend like I'm suddenly now part of the community, or that I am sort of a de facto Indigenous person that I can use the culture or the history as if it's my own. So it's important for me to have respect for it and have awareness of it, but not appropriate it. It's important for me to learn to give gratitude, but don't expect it. And so by this, I mean to be very thankful that you've been invited to go to these communities and to be able to engage in this research process. But it is not really acceptable for you to act as if people should be thankful that you're there. So you shouldn't expect for people to say, "Oh, I'm so happy that you're now here with this new equipment and doing these tests." The idea is that they've given you permission to be on their land, and you should have gratitude for that. And I certainly do. It's important to recognize your own privilege, but don't assume that because you have privilege that other people have none. And so I recognize that as a white person in a university in a well-funded research environment, that I do have privileges with that. But I also need to understand and respect the many strengths and sources of knowledge and wisdom that exist in these communities. And just because there may have some issues related to health in general and lung health in particular, that does not necessarily mean that everything or anything is really viewed out as a deficit. So to have an appreciation for that distinction. This one is kind of complex, but learn to appreciate intersectionality, but don't make generalizations based on your own experience. So this concept of intersectionality, where these components of power can be multi-leveled and multifaceted. So certainly there is power based on race, power based on age and privilege, power based on gender, and sexual orientation and gender identity. Many of these, and disability, many of these factors, of course, have different power levels. And so I appreciate that I don't understand all of the power dynamics that may be at play in a particular community. And just because I may have an understanding of what that it might be like in Vancouver, it might not actually generalize to life in a First Nations community. So I try to appreciate who may or may not have power in a particular community, but I have to make sure that I keep my opinions and my particular perspective out of that. A good thing to remember is that your work must benefit the community. The days are long gone where the researcher goes in, collects the information, writes their paper, and the communities themselves experience really no benefit. But with that, I also must remember to be transparent about the benefits that I do receive. So it is important that I be able to write a paper and how that impacts my career. I will be traveling and have the opportunity to talk to different audiences. That will happen. How can I also extend that opportunity to other members of the research team? How can we make that work? So it's important that we design the research to benefit the community, but also to be honest and transparent about how I also will receive benefits. And then the final thing, probably the biggest thing, the all-encompassing thing is just that I'm learning to be comfortable with being uncomfortable. So I'm always getting it wrong. I'm always not getting the joke if there is one, or potentially, seeing a situation that I misinterpret. I'm not probably ever going to be that comfortable. I'm always going to be in a state of wondering if I'm doing the right thing. And I'm just getting used to that. And I'm getting used to, experiencing humanity in all of its forms and just being appreciative of the opportunity to work in these communities. So that is the conclusion of my presentation. I would just like to acknowledge again the funders who have so generously contributed their money, their time, their expertise. So Canadian Institute of Health Research is now providing the bulk of the funding. The Lung Association gave us those first grants, which really helped launch the work. The Michael Smith Foundation also gave us that early planning money. And of course, Carrick Family Services provides their time, their expertise, their opportunities, and the way of opening the door to allow us to work together in partnership with these communities. So thank you very much. And I'm going to switch my screen now to my face in case there are any questions. So one moment.
Thank you so much, Pat. I love your presentation, specifically the last 7 things that you were explaining. You learned it was really awesome and a good lesson for us too. Okay, I'm gonna open the floor for the questions. We have only, I think, 7 minutes. So if you have any question, just jump in and ask Pat, please.
Hi, this is Lisa Thompson. I just had a question about the air pollution sampling that you discussed. How did you pick that strategy, and what time are you sampling, since it's such a short interval, to get a representation of their average measures? And finally, do you ask questions about indoor heating and cooking and in the presence of fireplaces and other sources of smoke in the home?
Yeah, thanks for the question. So the strategy was developed by Karen Bartlett, who has a lot of expertise in air quality measures and also a little bit of constraints related to our access. So we knew that we would have the opportunity to have a visit in the home. And so I had asked Karen, like, what can we take to to not intrude on people's homes, to not be there for an extended period of time, recognizing that we're not in the communities for much longer than a week ourselves. And we have a lot of houses to do while we're there. And so her suggestion is, let's take a few measures that will give us an idea about particulate matter, and a few measures that will give us the indication of ventilation, being around the carbon dioxide and humidity, et cetera. And then to take the dust sample, and with that look at different antigens and the components that might be in the dust, and kind of go from there. So it's certainly not as complete as leaving sensors in the communities for a longer period of time. Another thing that came up was should we be testing for radon? And the decision at the time by the communities was not at this time. Maybe that will be something that we can do in the future. With the questionnaires and with the inspection, yes, the questionnaires ask questions like, how do you heat your home? What fuels are you using? Also, do you use your stove for heating your home? Do you have a smokehouse for preparing meats? And are you also, in that environment? And then the inspection part will also do a walk around and have a look and see, is it a wood stove? A lot of people in this particular area are using natural gas. It's a bit unique in that it's along a pipeline, and so there are a lot of natural gas heated homes, but there are other communities for sure that we'll be going to that are predominantly wood smoke, or I should say wood stoves or wood pellet furnaces.
Thank you.
This is Jessica Kastner. Thank you for this excellent presentation. I'd like to know more about your thoughts and perhaps ongoing research questions about the intersection of gender disparity. In particular, given some of whether they be Métis or First Nations definition of identity as Indigenous were often applied differently to women, and particularly women who entered mixed-race marriages.
So is your question, are we seeing that expressed by the people that we are working with, or?
Certainly somewhat, as well as your thoughts on people who may have risk but don't qualify for that traditional Indigenous identity because of the way women were excluded from that through past treaty.
Mm-hmm. Yeah, so in these particular communities, we have people who are pretty much predominantly what we would call have status. And so a lot of the people that are still living on reserve are considered status Indians, using the old term. And in that, the status regulations have improved over the last few years. So people who did not, especially like you say, women who married out of either off the reserve or out of the First Nations community, then they would lose their status. That is slowly starting to get caught up. In our particular study, we haven't worried about status at all. It's just whoever is in that house. And in some cases, there have been a couple of people who have not been First Nations people, but have lived there their whole lives. It is certainly a large issue when we get into First Nations people who are living in urban settings, because a lot of those people have lost their status for a number of different ways, whether they've never belonged to a community that they know of, they haven't, they were fostered or adopted out of community, or like you say, they married out, or the number of different ways that they could lose their status. And at this point, we haven't done any working with urban First Nations people. I'd have to think, I guess, carefully about what that question is, and the partners would be quite a bit different. But it is certainly a concern around how people are identified, and how they access services is definitely based on their status.
Thank you.
Well, thank you so much, Pat. It's 3:00. We're gonna get disconnected automatically. So I appreciate your presentation, and I appreciate everyone else who came to the meeting. So thank you so much. If you have any question, I think that you can ask Pat later on through the email.
Absolutely, and thank you so much again for the invitation.
Yes, ma'am. Be safe.
Yes, thank you. Bye-bye.